you so much for being here. As you know, we're videotaping this so that other students in future classes can share with me your wisdom, if you don't mind, all right? So could you introduce yourself?
Sure. I am Shanna Merrick. I'm with the Addiction Services Council. I'm the Director of Youth Prevention and the Quick Response Team Manager.
In our course, we have firefighters, paramedics, and social work students. And starting in the fall, we're expecting not only undergraduate social work, but master's level social work. And I think that arose because the undergrads have said to the teachers that this is a real value. So could you share a little bit about your educational background and experience?
Sure. I have 27 years of nonprofit experience.
Right.
I have a master's in social work, bachelor's in social work, licensed social worker for the state, and a chemical dependency certification.
Oh my gosh. Wonderful.
So my background is in children's services, severely mentally ill children, severely mentally ill adults, working in primary care. I worked for Magellan in a special project with the county. And I have to say, no matter where I've gone, substance use and abuse has always been at least part of the equation in families that I work with.
And so now we've heard a lot about quick response teams, where you've got a firefighter, paramedic, a cop, and a substance abuse counselor visiting somebody in their home a week after they've been saved by Narcan. And I was amazed to learn that not only amazed that you've been doing many of these home visits, but you've been doing them in the community in which you live. So share what it's been like.
So I work with Coleraine Township, and it'll be 3 years in July that we began this project. And I really accredit much to what we do to Dan Malloy, who came to our organization. At the time, he was the public safety director of Coleraine, and we didn't have research to point to. He just said, I want to get ahead of this. We know that this is a big problem in our community. Will you help us go knock on doors for people that we know have had an overdose and see if we can't get them into treatment? And I just happen to live in Coleraine. And for me, it does take on special meaning because it is my community. It is where I live. And if we can provide any opportunities for help, a place to come to, people to talk to, give us input on what the needs of the community are, I think it matters. I don't want to say more to me than any other community, but because these are my neighbors, these are people that I see, I might run into at a grocery store. And so it's been very meaningful to me in that way.
Assistant Chief Will Mueller mentioned on our program on Monday that he and Dan and others have been asked to go all over the country to share this model. You know where the model came from? I had never even heard of quick response teams until we learned about Coleraine doing this.
Honestly,
yeah.
I have not seen I think maybe what might be a little bit of a spark to this is in Massachusetts is the ANGEL program. So that started before Quick Response. And so the ANGEL program is law enforcement just basically opening the door that if you have an addiction issue, you can just come into the police station, turn in whatever paraphernalia you might have, and if you say you want to go to treatment, they will help you get to treatment. And so I think that might have been kind of a catalyst to thinking of what can we do around community policing, public safety, community medicine. How do we engage, kind of cross these lines to engage with other partners in the community?
Amazing. So if right now a 911 call comes out, it's a non-breather, Coleraine Township, the police will respond, fire will respond, and both are equipped with Narcan. Patients given Narcan. What happens, I understand it's a Wednesday model, what happens next Wednesday?
So what we do is we sit down. It's almost like a briefing, like you would have, like we'd have ourselves, law enforcement, EMT, and we would pull out the police reports, and we utilize police reports because that is not HIPAA protected. So we have a way to gain information about potential clients' referrals. They've had this situation where they overdosed. We will review and look at each police report and the situation. There may be in the report other people that were involved in some way. Maybe they live in Coleraine, maybe they don't. So we're planning, we're determining our route. What's the best way? Coleraine Township is the 14th largest community in the state of Ohio.
Wow.
So determining where we'll go within Coleraine and best direction, whether or not this is someone that's already known to us. So we'll talk about that. What kinds of efforts have we had in the past? What kinds of barriers or challenges, just to kind of prepare ourselves before we knock on the door. The police will also look and see, is there outstanding warrants of some kind? So just to kind of prepare us for what we might encounter at the time of the visit. Does the person, depending on the kind of level of warrant, if they have to be arrested? So we talk about what that would be, what that would look like, making those kinds of determinations up front.
Wow. So there is a safety aspect to all this.
Absolutely.
So on a typical Wednesday, how many folks would be on your visit list?
It really varies. New referrals may be between 1 to 4, actually. So we've seen a little bit of leveling. I know that you'll read it in the paper. Like over the summer there were, 1 week in Cincinnati, I think it was like over 100 of overdoses. So, it may, and that's when we start looking for different types of drug that's hitting the street. So if it has the fentanyl, so we see this uptick in the overdoses. But we're also working a list. So that if I knocked on your door last week but you didn't answer or you weren't there and I've left literature, then I'm going to come back the next week. So we're also looking at our new referrals in addition to who didn't we see. We do know enough now in terms of data that if we have a face-to-face interaction, we are at a much higher opportunity of success in engaging someone and getting them into treatment.
So paint me the picture. You're knocking on the door of a new client and he or she answers the door. Did they know you were coming?
No, they do not. The EMTs may say that at the time of the actual incident when they've used Narcan and they've done the revival, that someone will be coming. At this point, it's well known in Coleraine that if there's been an overdose, someone will be coming. But we don't set up an appointment or a specific date or time, or we just get together, come out, knock on the door.
Got it. And I've seen the SUV, driver side, Coleraine Police, passenger side, Coleraine Fire and EMS. All three of you show up. Who's in uniform, who is not?
EMS and law enforcement are in uniform, and then we are business casual.
Got it.
We try to work for community.
Okay, so knock knock, and let's talk. There she is. Okay. All right. Kids may be in the house. Whatever. Take us forward. What happens? What's the scenario?
Typically, law enforcement and EMT, honestly, they will knock first, and I'm usually right behind them. And really, a big part of our work and collaboration is the messaging to the clients, the patients that we're working with, which is, the first thing law enforcement says is, you are not in trouble. I am not here in necessary, around some specific law enforcement issue, we want to help you. We've brought someone with us. This is our EMT. Here is our counselor that we work with from Addiction Services. We know from this police report that there was Narcan, that there was an overdose, and we want to know what we can do to help you. And then really it just opens the door to, I may at that point intervene and say, okay, tell me about what happened. Tell me about that incident. Can you tell me if you've been in treatment before? Can you kind of give to me a sense of kind of where you're at with addiction?
Wow. And all right. And someone shares the story. What's the next step in that person's recovery life?
For us, it is all about, I'm going to pull in stages of change. So if anyone's familiar with pre-contemplation, contemplation, those stages. So we are always trying to move to a place of action. So even if someone's in pre-contemplation or contemplation, or even they're thinking about and they're getting ready to make some changes or choices, because oftentimes I might raise my hand and say, I want to go to treatment. And I think this is that's not clear to the general public, is just because I raise my hand and say I want to go to treatment does not mean I get to go to treatment. We have a lot of restrictions around, do you have insurance? If you don't have insurance, is there indigent money that perhaps we can help to finance the treatment that you're interested in? Can we sign you up for insurance? Do you even have a valid ID? Because every treatment facility is going to ask for some kind of identification. And these may be things that that people have lost along the way. So even though it's getting to the heart of kind of what's going on in terms of addiction, what are the barriers because that can create a lot of hopelessness, that people may have tried to call a facility and they found themselves on hold or on a wait list, and then they found out they didn't have any of the proper documentation that they needed. They may not have transportation, may be another big barrier. So we're really trying to look at all the holistic person and what their needs are and how can we get you to this next place. So one of the first things I'm saying is, will you come we work at the police substation. It's called the Community Resource Center in Corrine. Are you willing to come in?
It's not located in a police station?
It's a separate... most people, it's a building. It's really kind of funny, the history of the building. Right. It was a bar.
Right.
And then the police bought it.
Better place. Right.
And it's right in front of an establishment that is at one of the kind of really just pay-by-night hotels that may, house people that don't have a lot of money. And so we're literally right in front, so people know where it is. Sure. They either remember it as the bar, or they're like, oh yeah, we've passed that. Right. So we work out of the substation, and what I'm trying to engage people, can we go in right now and just sit down? Sometimes we can do interviewing, obviously in the home, but if we want to do an assessment, we're trying to find a place that just has a little more privacy, a little more, that's still close in the community. So I'm not asking you to make this appointment and come to Clifton.
Got it. So with that hypothetical young lady that we're talking about, you ultimately make an appointment with her at that facility.
Mm-hmm. And it may be right then. It may be if I can get back, because on my team there are two others. That's a case manager and a peer recovery and a clinical triage specialist. And so we have someone kind of manning the station at the time that's sitting there sort of waiting, sure. And someone that's out in the community riding with law enforcement, sure. And EMT.
So take us forward. She now shows up at the appointed time. Again, that path to recovery. What happens next?
We just decide whether or not do you have an assessment. That's sort of the opening to the door of the first thing that we do. Have you had a drug and alcohol assessment? If you've had one recently, then honestly, I'm going to start with paperwork that's releases. Because I want to get a hold of that. Because I don't want you to have to go through the whole assessment process if you've just done this. And then we start talking about what kind of treatment depending on what the assessment may say. The assessment may say you need higher levels of care. People may or may not be ready for that, and or facilities may or may not have capacity. So then I'm looking at, all right, if we can't get into residential treatment and you're ready, and do you have a stable living environment? Do you have resources? Do you have some supportive people around you? Because that's something that we could think about in intensive outpatient or medication-assisted treatment that's right in your community. So we may start calling places at that point and really working with the individual. Like sometimes it's really been, I've dialed the phone and handed it to the person and they're ready.
Yeah.
And they're giving the information and making the arrangements. And they really just needed somebody there to support them so that if they ran into a barrier or a question that they don't know the answer to, they have someone that can say, oh, I can help you with that.
Wow. So yesterday we were at the Center for Addiction Treatment, what I call the Cat House. Mm-hmm. And there are residential treatment, 28 days, but there were also a whole lot of people in the hallway of the new building in which we're in, and they're there for medication. Some have not been through the 28 days, so it's a very busy place, as you saw. You know, men and women and children, a very busy place. So I'm learning about these two modes. One is a 28-day residential. The other is this treatment facility. Kind of give me a range of treatment options that your residents might avail themselves of.
Okay. So for someone with the serious high-risk opiate addiction, I mean, my suggestion would be, if we can't get into residential, then I would say an intensive outpatient. And if you're willing to do medication-assisted treatment and that works for you in terms of your journey of recovery, to couple it with that.
And that would be the Suboxone or the Vivitrol?
Right.
Okay. And is that taken orally or is it by shot? Or?
The Vivitrol is by shot and the Suboxone is either a strip. Is it a pill too? Okay, so I know it's a strip and a pill.
Got it. All right.
So you make
so that's
really,
one option.
Right. So that's one option.
And that's a patient option. The patient
yes.
has to say, I want to do that. Okay.
Yes.
All right.
And the intensive outpatient can be anywhere from 3 to 12 hours a week. So it's several hours at a time. I don't know if you've done any work with Brightview. So I've gone up to their facility. That's an intensive outpatient medication-assisted treatment facility. And
they're located where?
They have one in Coleraine.
Okay.
They have several locations, okay. But we were very excited to have one in Coleraine. For as large as Coleraine is in terms of the size of the community, there were no treatment options in the community until Brightview came. There are 3 self-help groups in the community. So it is very...
Are these like what I know
like an
AA
meeting, or an NA?
Our church has an AA on a Friday nights. Okay.
And there's only 3 in Coleraine.
Wow.
So you've already got very limited resource in the township itself. But when Brightview came, and it's accessible, it's right on a bus line, people know where it is. So they may go, it's very client-centered. That was kind of where I was going.
Sure.
So when people walk in, it's very welcoming. They may be there 3 to 5 times a week. And that's a big, I have actually had a person that I worked with. This is an interesting story. He actually overdosed, but was homeless. And so at the scene, the EMT and the police officer they said, look, if you really want help, we have help here. And you can go to this person. Because of our resources, we only work on Wednesdays, so we have a limitation to that. You can go, they're up at the Community Resource Center. I also, in the evening, I do work at Northgate Mall. There's another police substation, and I'm available there. And he came and found me so that he could, because he wanted to be in treatment. I would say the other that I think is somewhat, I don't want to say it's a myth, but I think it's disproportionate. The majority of people I've met have wanted to seek treatment. Their barriers were too high. The majority of people I have met do not want to live the life they're living. They're living with shame and sadness and frustration and anger. They've isolated and alienated themselves from family and friends. So I think for people, I think that cycle continues because of all the negative, that comes with addiction.
And we're talking about you're rendering these services in the community in which you live. So I can just imagine going to the Kroger's, going someplace, and there's patients interacting with you in an unscheduled way. Does that happen from time to time?
From time to time. And I follow our code of ethics, it's a short code of ethics, which is I don't address anyone unless they address me.
Got it.
Because I don't want to infringe on their right to privacy.
So from a data collection point of view, roughly how many interactions have you had?
Can I go back a little bit to the man that was homeless?
Oh, yes.
Okay, so we couldn't get him into a residential facility because we couldn't find one that had availability. And he started at the intensive outpatient medication-assisted treatment and was totally successful. And eventually found housing. But so it said to me...
Can you give them a time frame on that?
About...
how long it took him to get into treatment.
With Brightview, he got in that week.
Yeah.
It might have even been the next day. It was really that quick. Like, we made the call, and he was able to go and get engaged. And we did not want him to maintain homelessness. No. So we were trying, but he did not want to go to shelters because they were all outside his community. And he had a personal connection to someone else that was homeless. And so he didn't want to leave that person. So we were just kind of going with, again, where the client is at, what their willingness, and we were just supportive. He would come and see us every Wednesday. Just to stop in and say, I'm still going to treatment, and looking better and better every time. He did find housing when he was ready. Honestly, when he was ready to do that, he was able to find housing. But it kind of gave me a sense of how dire a situation can be, truly. And that the human spirit, in terms of willingness and motivation and engagement, and he was ready, and it didn't matter that he was homeless.
Amazing.
So that was
wow.
amazing.
So I was asking about the big picture data.
So I have to say, so we're coming on 3 years in July. The first year and a half, maybe a little longer, we were using an Excel spreadsheet. Mm-hmm. Now, that was totally unwieldy. We couldn't get it to do all the things we wanted to. It was challenging to calculate, but we couldn't use our electronic health record because not every door we knocked on did that person necessarily get an assessment or become our client.
Sure.
So we just, in the last 6 months, began using a system called Core Data. So I can tell you in the first year we had 283 overdoses.
Wow.
And I'm not going to be good on the fast math on this. If we had face-to-face engagement, that's a critical piece for us, 85% went to treatment.
Wow. That's an amazing success story.
But the face-to-face is really was really the key for us. And again, I think it points to the majority of people not wanting their addiction is unbearable to them too. So I think we kind of give this message. I think I get sad when I see messaging in general community, whether it's on social media or, it's their choice. And I would agree with that the first time you do it, that you made a decision, a choice. But addiction takes over the brain. I mean, I know you know all of this.
Well, Dr. Richard Ryan gave a 45-minute lecture yesterday, and I've posted it on our UC Fire Science webpage with his permission. And he's talking about, brain, all right? And this is a disease of the brain.
Mm-hmm. So maybe that first choice happened, but once addiction is setting in, it is physically changing your body. So...
Wow. Great success stories, but there has to be some non-success stories. Have you had some folks that have not gone well?
Yes, we've had, and I have to say, because all of you are helpers here in terms of, and I'll just share this story. So we're knocking on doors, we get people in. I'm all about how do we move to action. I really think it's about engagement. How do I truly start where you are at? How do I provide the assurance that I'm here for you? What I think law enforcement and EMT does not get to hear enough of is because they're that front door first time, but then I have all these subsequent interactions with people. And over, clients will say to me, I can't believe they cared about me. I can't, now I have a relationship with a police officer. It's like mind-blowing, like for them, that I didn't get arrested. You weren't trying to, and that has been a huge a source of support for many of the clients that I work with, is knowing that they feel they have positive engagement and positive relationship with first responders. So some of our not successes, I met a man, he came in, and you can with years of addiction, with different kinds of addiction. So he, in addition to heroin, he had many years of alcohol use. And so he was, really when I met him, really like tired, and you could just kind of see some of that hopelessness in that, but he was willing to engage. He was willing to try. Well, we had made a subsequent appointment and he didn't show up. And so I was like, hey, we need to go back out when we're doing our rounds. Let's not go knock on his door. Well, and he was a roofer, and we get to his house, and I looked on the porch and I thought, oh, thank God he's here. Because I saw boots with tar on them sitting on the porch, and I thought, oh, good. So we knocked on the door, and the roommate answered and said, oh, he died last Thursday.
Oh.
And literally, like, heart sank, brought tears to my eyes, because that's the reality and the nature of this disease.
Oh.
And the challenge it is for people to truly like stop on your own. If you don't have the supports that you need.
Indeed. From a financial point of view, who's paying for your services?
If we do the assessment and someone has Medicaid, then we will bill Medicaid. We are fortunate that we also receive indigent funding through our county board, so that it can help kind of close some of those gaps. The Hamilton County Heroin Coalition has also provided some opportunities for us around funding. But that's what kind of speaks to some of our resource issues, that we can only dedicate right now, 1 day a week in order to do this.
The Ohio Attorney General's office has, I think, awarded them $50,000.
Yes.
Hoping that this will go from a Wednesday only to a Wednesday, Friday. Any clue when that might?
Well, so we have that, but then the coalition has the Hamilton County Heroin Coalition is also starting a countywide QRT. which will begin April 1st. And so though Coleraine will remain a separate day and time, we'll be also utilizing, at least in the beginning, 2 days, if not 3, where we're looking at kind of hot spots in the county and just dividing it east and west. So it is growing in regards to the model of care.
Yes. So we're blessed that about half of our students are UC social work students taking a course in UC fire science. I love that model. It's wonderful. From their educational point of view, if this was a line of work in which they'd want to go, what's the path? How does one go from undergraduate studies into a career such as you are performing?
I would, in order to, I have to say, I mean, in the field, I would encourage graduate to get to the graduate level, to get a graduate degree. I think that offers a lot more opportunity, because what I like about the position I'm in currently is I can be clinical triage intake, I can be the case manager, and I can be the assessor to do the assessment and, if needed, ongoing individual and group treatment care. And so I think, and with that, I think came with my having a graduate degree, having that licensure, getting the certification. So you can be that person that can be very flexible and provide a variety of services within a community.
So when we're not on duty on the Wednesday quick response team, you're back at the Addiction Services Council. From your experience with quick response teams, has that enhanced your professional skill set dealing with your other clients? Has this been a growth experience for you personally?
Absolutely. I think when it comes to addiction, it really, I feel the other, I would say, is I think anybody and everybody should do some level of community work, because I think it offers perspective to resources, the challenges, the barriers. I mean, when you're sitting on someone's front step and really engaging in what day-to-day life is for someone else, and it's harder to really feel that when you're in the office. So I'm not saying there's anything wrong. I mean, we need office work and people need to be, you need privacy. But I think if you can go out into the community and have an understanding of someone's and really see through their eyes, kind of in terms of empathy that you would have, and the perspectives around their life. I think one of the things that I've learned a lot about is trauma. And so when I think about like the ACEs study or many addiction assessments that I've done, a high percentage, I will encounter the person will share some level of trauma. And so I think understanding trauma work and how that plays into the services that you're providing has helped me, and I'm seeing that. So the community work, I think, has really enhanced my ability, I would hope, to be more empathetic and action oriented. We talk about motivational interviewing. It is hard to do. I think as a social worker, I am very geared around action. I'm very geared to.
What is motivational interviewing?
So motivational interviewing
I can do that in my law practice.
Talking more than is listening more than I talk.
Oh my gosh.
Is asking to rephrase what you've said. So it's kind of the epitome of client-centered. And it's really me like sitting on my hands and having a lot of awareness, doing a lot of repeating back to ensure that I've heard you, because really people want to be heard. And so motivational interviewing, in terms of, that's really starting where the client's at. So it gives me the understanding of where are you in the stages of change? What is your readiness to change? What is your motivation? What are the barriers that are kind of holding you back? But it really requires a skill to be that listener And again, I think as a social worker, and it could just be me as a person, I am very, what do we do next? What do we do next?
Oh, indeed.
At
Go ahead.
UC, we actually basically take a whole class on exactly that of just like motivational speaking. Did you guys have Dr. Yeah,
Yeah.
it's a fantastic class.
Yeah, it really shows you the process that you may go through, even if a person's in recovery, about what they would have had to go through to get those services.
It was one of my favorite classes, not only just because that was one of the classes where I just learned so much, but also the professor was very helpful, always reached out and like would sit down with each group and just say, all right, now take it this step further and take it, maybe from this point of view.
What could you have done differently?
Yeah, so it's one of my favorite classes.
Yes, being comfortable with silence.
Oh, that was definitely the
really-
hardest part. That was day one, is being comfortable with silence and just letting them think things through.
Oh, this
It
is
gives you
hard.
chills at first, but you get used to it.
Asking them to rephrase is huge, just so you can understand how what they actually mean, and if that's the way.
This
they
might
want
help
to
in
put it.
marriage counseling as well.
Couldn't hurt.
Right, can't hurt.
I actually have another question. My current track is geriatric care, and that's where my field placement is going to be for next year, my senior year. And they also are thinking about hiring me after graduation. They've hinted at it more than once. So I really am excited to go and work for that nursing home. But is this something that, if it was introduced to my community, that I could do on the side, just 1 or 2 days a week? Is that something that's possible, or is it more time consuming?
It actually is more time consuming
Okay.
because the interactions maybe, so I've met with, Sally Sue today, but then even if I'm not seeing you tomorrow, perhaps I'm calling all the referral places, I'm thinking about what our next steps would be, I'm still kind of gathering information, so for the counseling part of it goes into other days.
Okay.
And we will even, I might say around engagement, can I call you tomorrow? Can I, so even if, I'm trying to look for any opportunity to make sure that we stay connected. So law enforcement and EMT, that the collaboration is really at the front door of that first visit. But for us, in terms of the longer term work, goes into other days.
Did you already talk about the AC?
The ACEs.
CDC.
Oh no, CDCA.
Yeah, the requirements and the licensures that you need to work with individuals who may be having behavioral health issues.
For us and the certifications that we do, it is very hard for us. Desire can be a testament to this, to have undergraduates that have in internships that don't have any certifications, because it limits the kind of client interaction that you can have. So if you can get a CDCA or something of that nature, that's really very helpful. It's a 40-hour training. I believe you could do some of it online through eBased Academy or other, but it's a very helpful. So to at least have that piece of it, that's going to give you all the specific substance use disorder information.
And have a car. That's all I can attest to.
It
Very
is
helpful.
very challenging. Yeah, it's helpful to have transportation. That's true.
You mentioned that starting in April, quick response teams countywide. What do you contemplate how that's going to be managed? Where are folks going to be going for the follow-up? This is going to be a real challenge because our county is beset with drug overdose problems. So what's your take on this?
Well, my take on this is I believe that Amberley Village is really our champion, that we will be working in conjunction with their law enforcement. Honestly, I always perceive it as, let's get the list, let's figure it out, and I'm just let's go do it. One of the things that Dan Malloy said when he came to visit us when you very first brought this idea, it's really the thought of, I mean, doing nothing is worse. So even if we're a little bit fumbling and figuring it out and getting to the, how the technical pieces will work.
Right.
Because one of the things we learned is we use a system called Core Data now to track up all of our information. And technically I could be doing that in the field, but sometimes if I'm standing in a hallway it's really not convenient to pull out my laptop and try to input data. So we're learning things along the way. I think that having made at least this division between, we're going to do like east side this time, west side this time. The biggest pieces to me that are critical is the engagement, that the collaboration between law enforcement and EMT. You have to have a true champion from each of these, like anything. And I don't know a better way to say this, but it's like if you're not a believer,
Yes.
that knocking on this door is going to make a difference, or that people read right through that.
What's the Amberley Village role?
I think because they're assisting us in terms of, that's where Lieutenant Fallon,
Yes.
and so he's going to really be our catalyst for getting this off the ground, and that's where he
Right.
currently.
And by the way, I don't know if you know, but Amberley Village is one of the few in the United States where the police officers are also trained as firefighters.
I did not know
Yeah,
that.
so they're
So they
cross-trained.
totally
So
understand,
It fits right in.
So
Fantastic.
Amberley, like Ember. Okay.
No.
Wow.
that's awesome.